Well, after this wonderful lecture, it's now time for, I think, the last session, although there will be other activities after that, but the last session, which is devoted to metals and the liver, something very interesting. We have excellent speakers who are also excellent investigators. And we will have a small change by comparison with the program. We'll begin with iron, with Antonello Pietrangelo from Modena to speak about this topic. You know how a wonderful lecturer he is on this topic. Listening to him, we always understand all. The problem is 2 weeks after that, where are we?
Thank you very much. It's a great pleasure to be here. Thank you for the invitation, and thank you to Peter for allowing me to switch my talk. So this is, of course, that's my topic, but the good news today that I have only one slide on hemochromatosis, and in fact, I will tell you about how this field has really exploded due to recent discoveries, and how this is now affecting much more than hemochromatosis, and now is really going through many other areas of the liver, but also of medicine. So this is basically
Is it your presentation?
Yeah, it is. Pietrangelo is there, you see. It's me, and so that's basically the history of iron in medicine since it was first identified in the blood. So it's a long history, but the really breakthrough in this history has been in year 2000 when we have got an hormone produced by the liver. So this has been the real discovery because it's changed completely our understanding also of the role of the liver. The liver historically was just seen as the depot, just where iron goes when it's not needed by the body. But after this, all of a sudden, the liver was at the center of iron metabolism because of the hormone, very similar to what happened with the pancreas with its hormone. So this has really changed our perspective. And has been the first revolution. Maybe it's not the right word to use nowadays, but again, this was has been the impact in our field. So what are the implications of this incredible discovery? Now, first of all, epsilon, the hormone, is actually, this is a surprise, was a surprise for all of us, an antimicrobial peptide. And this was very strange, of course, is made by any living organism. In Drosophila, interestingly, is produced by the fat, which is the homologue of the mammalian liver. And in mammals, it's almost only produced by the liver. So why a defensive is the iron hormone? So this takes us to the main, one of the main messages of my talk. So it takes us to the pathogens. We have to consider that bacteria or probacteria has been the first on Earth to use iron to make life. They use the capability of iron to switch between iron 2 and iron 3 to make actually life, things happen. And iron is essential for any possible microorganism, bacteria, fungi, or protozoa. Actually, the virulence of any infection depends on the amount of iron that the pathogen will find in our body. So whenever a pathogen is entering the body, the pathogen looks for iron. It tries to steal iron from us, from our proteins, like transferrin, lactoferrin, or even hemoglobin. So that's a very interesting story. And we know that iron overload, in fact, favors infection. This has been known in humans with iron overload due to genetic causes or acquired causes. We know, for instance, that malaria is much less frequent, less severe in iron-deficient patients. We had a really disaster in Africa when in certain area was given iron to young boys or person with malaria. Was really dramatic, the impact of this iron supplementation. And we also know that infection due to virus can be facilitated by an iron environment. So the gatekeeper, so epsilon is the iron gatekeeper, the antimicrobial peptide, because it is a priority for humans, of course, to be protected against the pathogens. What epsilon does when it's produced by the liver, a very simple thing, it blocks and degrades the only iron importer we have in humans, which is ferroportin. Here is the enterocyte, ferroportin is there, the basolateral site toward the blood. These are the macrophages, but the same thing happens in placenta or in any cell. So touches ferroportin, goes inside the cell, and it is basically degraded. So iron, the transfer of iron is blocked. So it's a negative regulator of iron income. Now, if the stimulus is protracted, so in acute infection, after the acute infection, everything goes back to normal. But if you have, in a chronic situation where you have continuous stimulus, interleukin-6 made by the liver, more epsilon is then produced. So in this case, you can end up in the famous, very famous actually, it's been for many, many years, anemia of chronic inflammation that you find in many diseases, because at the end, iron is not entering the body, is not released by the macrophages, so you end up with an anemic state. We've been looking for years who was actually responsible for this, and actually epsilon is the major factor involved in anemia of chronic disease. Interesting for us, the link was found in patients with liver disease, with adenomas in the liver, with familiar adenomas producing epsilon. These people without any infection had a very severe anemia, very similar to anemia of chronic inflammation. After the adenomas were removed, everything was fixed. So this was the proof of the role of hepcidin. This is a slice of a liver, and the white grains are basically is the messenger RNA for hepcidin in the liver, which is expressed periportally. You see, these are the central vein. And now, if you just give one injection of LPS to this animal, you have an explosion of the transcription of the gene, just to give you the sensitivity. It's very sensitive to the infection. This is a very nice story. A few years ago, we found a mutation in ferroportin, which is the transporter. This mutation was only present in Africans and in Black Americans. We had no reason for that. We could not understand why. This mutation makes ferroportin insensitive to epsilon, so ferroportin keeps sending out iron from the macrophages. In fact, this patient had macrophages with low iron. Finally, last year in Science was published this paper. It was found that this mutation protects against the malaria, as I told you before, because the Plasmodium was finding an iron-deprived environment in the macrophages. It could not go on with the cycle. So this was very interesting, and tell us very much how important is this iron for the pathogen. Other interesting paper has been now published in experimental pneumonitis due to Klebsiella, for instance, was seen that if you give iron to the animal, the infection will worsen, will be a dramatic negative effect. Same thing if you do this in animal without epsilon, but if you provide mini epsilons, so you give the hormone, everything goes back to normal, the animals will survive. We had another paper, a confirmatory paper in blood using other experimental model with Yersinia enterocolytic. Again, without epsilon around, there was free iron in the blood called non-transferrin bound iron, NTBI, and the pathogens were very happy. But then if you give epsilon analog, you could control the infection. So this has been very important to support a key role now of the liver, of course, which was known, but true epsilon has really a central role in innate immunity and in host response to infection. So now what about, how the liver can sense iron, to have this kind of response? Now, this is just a schematic representation. This is a sinusoid. Transferrin iron is coming from the gut, then will go through the pores to the membrane of the hepatocyte. Here you have a number of proteins which are the sensor for transferrin saturation. So this is the sensor to tell to the liver make or do not make hepcidin. Now this sensor is made by a number of proteins. Now if one of these proteins is missing, genetically of course, like HFE, TFR2, or you end up with a well-known old disease called hemochromatosis. In fact, if the protein is not that important, for hepcidin, you have the adult form of hemochromatosis, or if it's enough important, you have an intermediate form, which is transferrin receptor 2 hemochromatosis, or the very severe form to the major controller, which is hemojuvelin. So that's the only slide on hemochromatosis, but just to tell you, how the system works. Well, the implication of this, that first of all, hemochromatosis is an endocrine disease exactly like diabetes. But on the right part here of the slide, it is important that if you accept this model, we must accept that if you have a non-genetic failure of the liver to produce hepcidin, you will end up with the same situation. So you may end up in an acquired form of systemic iron overload of hemochromatosis. And this is in fact the case. Several papers have been published in non-hemochromatotic patients with advanced cirrhosis of acute liver failure with a systemic iron overload in the heart, in other organs, very similar to hemochromatosis. So the end of the story here is that the progressive loss of functional hepcidin or transferrin producing liver mass as occurred in advanced cirrhosis, acute liver failure, will lead to increased transferrin saturations, not like in hemochromatosis, but is just a significant increase that will negatively affect the prognosis because this kind of free iron has a proximal role, but also because, as I told you, this iron is very good for siderophilic bacteria, which are quite common, as you know, in cirrhosis, and cirrhotic patients are exposed to this kind of, are very prone to this kind of infections. So another implication that we have learned is that many factors involved in liver diseases, like alcohol, HCV, or hypoxia, can directly touch the promoter of hepcidin, so can control hepcidin. So which means that these factors per se can modify the level of hepcidin expression within the liver, and this can affect the deposition of iron in the liver, not systemically, but may this iron in the liver favor the progression of the liver disease. And indeed, we all of us know about this mild, moderate increase of iron in the liver biopsies of our patient with NASH or with alcoholic liver disease of chronic viral hepatitis. Iron can be in the macrophages, in the hepatocytes, or more frequently is a mixed pattern. And there have been many studies. These are just part of the study. Most of them suggest that at least the presence of iron is a problem for the progression of the disease, so can accelerate somehow the course of the disease. Of course, we all know that all the other studies trying to remove this iron have not been very conclusive in terms of the efficacy, but there is quite a general agreement on the fact that iron there, even that much iron, is bad for the underlying liver disease. So the second revolution in this field, this is the last part of my talk, is that finally we have an etiologic cure. You know, going back to the history of iron, in 1950 was first introduced phlebotomy, and we are still there. So that's the only way we have to remove iron, which is not a good way to remove iron because it is a dramatic way to change the iron homeostasis in our body. So finally, we have the hormone, is a liver hormone, which is very good for us. And this is just a short list of the many project studies and trials that are going now on, trying to modulate hepcidin. So we, depending on the disease, if you have a lack of hepcidin, like in hemochromatosis or other condition, you may need hepcidin itself, or mini hepcidin, or the analog, or anti-hepcidin inhibitors like antimatrix 2. On the other hand, that's the big pharma are very much interested on the other side, on the anemia of inflammation, which has an important impact. So there is a lot of work there. There are many strategies there that are trying now to, put in place. So these are just few of these trials going on. Some of them are already are phase 2 studies. These are in beta thalassemia and in hemochromatosis using hepcidin itself. So the hormone is a subcutaneous weekly injection. But there are other trials that are being done that using the inhibitor, to block the inhibitor of hepcidin, or others are trying to target ferroportin, so are just in phase 1. And so this is basically very exciting, of course, for all of us. And the aim is to have finally possibly an oral hormone to be used in our patient with iron disorders. So the final messages are the following. So the liver is the central regulator of body iron homeostasis as the main source of hepcidin, the iron hormone. The presence of hepcidin or hepcidin induction during infection limits or prevents the formation of a circulatory free iron pool that fuel siderophilic bacteria overgrowth and spread. We know of this now has been quite clarified. The genetic loss of hepcidin or hepcidin ancillary regulators like HFE cause hereditary hemochromatosis, very much well known. But we now have learned that acquired loss of hepcidin producing liver mass in advanced cirrhosis or acute liver failure cause systemic non-hemochromatotic iron overload. And this, of course, may affect the prognosis of our patient to a pro-oxidant damage effect, but also, as I show you today, by favoring or worsening the possible infections. And now the real excitement is about the manipulation of hepcidin synthesis activity of the hepcidin replacing strategy, which may represent for the first time after many years the first etiologic cure of iron-related disorders, but also of other important human diseases. Thank you very much for your attention.
Thank you very much, Antonello. I think we can take one burning question, not more maybe because of we are far beyond the schedule. Just one question. Is it clinically possible and useful to determine hepcidin level in blood?
Yeah, I mean, it is now possible. We have commercial available, quite sensitive methods to do so. The real problem is that hepcidin is an acute phase protein. So you have to, as a clinician, you must be very careful in the interpretation because it's very sensitive to many signals, even metabolic signals, gluconogenic signals can affect the transcription of the gene. So you must be very careful, but now it is possible to measure. And also the NTBI, which is even more interesting in some terms, is quite expensive, but it is measurable. And this is going to be another interesting tool for us.
If not, thank you very much, Antonello. Thank you. I hope you will be able to catch your flight. So it's now time to introduce Peter Ferenczi from Vienna. You know that Peter has been involved in a number of areas in hepatology, but I think that one of his earliest, probably dearest involvement has been in Wilson's disease. So he will tell us about copper and the liver. Peter, please.
First of all, good evening. I'm happy to be invited to give this presentation, and I hope you will learn something new about copper. Copper, I think is important, is an essential micronutrient. The big problem with copper is it's highly toxic at the same time. So we have very important metabolic processes which protects our cells against copper. Copper is constituent of several oxidase enzymes, including cytochrome C, superoxide dismutase, for example, dopamine beta hydroxylase, which is both involved in oxidative stress reduction and also in the function of several neurotransmitter systems. The liver is the main storage site for copper, and as I said, non-protein bound copper is highly toxic. And therefore, both high and low copper levels have a pathophysiologic relevance. We have diseases with too much copper, like Wilson's disease I'm going to cover, cholestasis, which I'm not going to cover, and other inborn evidence of metabolism. And then we have copper deficiency, and only will cover the cooperation NASH and copper. Let's start with Wilson's disease. In the short time I have to present to you, I have to give you a presentation, I'd like to point out to many misconceptions of this disease. The first one is that Wilson's disease is a very rare disease. There are very recent data from the United Kingdom and France which give you the heterozygote frequency with 1 to 21. I'm not going to discuss these studies in detail, but if you take these numbers as correct, which I doubt there are, it should be at least 60,000 patients in the European Union with Wilson's disease, which is far from what we know. Wilson's disease is not a childhood disease. It occurs at any age. Wilson's is not just a neurologic disease. It's first of all a liver disease. And then the biggest misconception that you can exclude Wilson's disease if seroplasmin is normal. This is a cartoon of the Wilson's disease gene, the ATP7 gene, which basically consists of a copper binding domain, a copper channel, and the ATPase, which provides the energy for the copper transport from outside, from the cytoplasm into the trans-Golgi network. These are shown the several exons of this gene. I cannot go into detail, but these are the mutation hotspots, exon 8, 13, and 14. Now, what is copper doing in the liver? First of all, copper comes from the nutrition. It's taken up by a carrier, and first of all stored in a protein, metallothionein. In this form, it is atoxic in the liver cell. At a high copper content, copper is released from metallothionein and immediately bound to another protein called ATOX1, which is a copper chaperone to protect the liver from the toxic effect of coppers. And ATP7B has a copper ATOX binding site, and copper is taken up in the trans-Golgi network, where it forms lysosomes, which then leads to the excretion of copper through the biliary tract. Under normal conditions, when we need copper-containing enzymes, copper is also released from metallothionein bound to ATOX1, and then also transported in the trans-Golgi network, where it is combined with a protein, aposeroplasmin, to form seroplasmin, which has nothing to do with Wilson's disease. It's a very important iron oxidase and gives you the link to all the factors Pietrangelo just showed to you about iron. It's part of this defense system. Now, there are other copper proteins which do not require ATOX1. They have the several chaperones and are responsible for the synthesis of other copper-containing proteins. In Wilson's disease, mostly this part doesn't work. We cannot excrete copper in the biliary tract, and you have reduced production of whole seroplasmin. Now, we have learned a lot about the disease of Wilson's disease. It's not an easy disease. You see, in this cartoon, it starts at life. So if you would do a biopsy in a neonate, copper would be already high, and signs of steatosis may be present. And this can go on for the whole life without any symptoms. The patient can just for some reason go to the doctor, for example, the draft for the army, find high ALT, and is found to have hepatic Wilson's disease. After a certain time, patients may develop symptomatic liver disease, which may present either as fulminant liver failure, as Coombs negative hemolytic anemia, or any form of cirrhosis, compensated or non-compensated cirrhosis. These patients may, but do not have to have neurologic symptoms. It takes longer for patients to develop primary neurologic symptoms. It's about 8 years difference in our large database, which is online available in hepatology. And these patients may present with both psychiatric and neurologic symptoms. They may have liver disease, and we have this mixed form of presentation. And some patients, and that's the big question mark, may never become symptomatic. As hepatologists, we are interested what happens in the liver. The most common feature in early Wilson's disease in young people is simple steatosis, which may evolve to NASH-like picture, or they may show the typical autoimmune type hepatitis picture, and finally end up as cirrhosis. Now, you see here the age of onset of symptoms in patients. What you see here, the black bars are patients presenting with liver disease, the white bars patients presenting with neurologic symptoms. In the age group of children and young adults, the liver is predominant, so most of the patients present with primary liver disease, whereas in adult populations, it's more neurologic symptoms. But still, even in the old age group, above 42, the oldest patients I have seen is 74, patients just present with liver disease without any neurologic symptoms. So the take-home message from this slide is patients may become symptomatic at any age. A second important point as for hepatologists is what is the liver doing? You see here the green bars show patients who have no cirrhosis, and the purple bars patients who have cirrhosis by histology. And what you can see again in the children, non-cirrhotic disease predominance, whereas from the late adolescence until any age, it's about 50-50. Half of the patients have cirrhosis, half of the patients are non-cirrhotics, and we have seen patients at the age of 50 having a totally normal liver biopsy. The take-home message from this slide is only half of the patients develop cirrhosis. So what is the diagnosis for Wilson's disease? We have a lot of clinical symptoms. We have the Kaiser-Fleischer ring, which may be present. We have neurologic symptoms which are present but may be non-specific. We have ceruloplasmin. I'm going to in detail on this one. It may be normal in patients with hepatic Wilson's disease. On the other hand, it may be low in malabsorption, urinary copper excretion, hepatic copper content, and we have the genetics. Now, ceruloplasmin, and that's the third take-home message, is a terribly poor screening test. It has a sensitivity of 3% to detect Wilson's disease. Low ceruloplasmin has a very low sensitivity and extremely low specificity. So if I'm always laughing if you see research protocols which exclude Wilson's disease by having a normal ceruloplasmin. It's absolutely wrong. Ceruloplasmin levels are increased by any form of inflammation. If they have hepatic Wilson's disease with intense inflammation in the liver, ceruloplasmin is high. And very important, female sex hormones increase ceruloplasmin levels. So for example, if you have a young lady coming into your office taking the pill, she has normal ceruloplasmin, although she has Wilson's disease. On the other hand, ceruloplasmin is decreased by any form of low copper supply, a very typical finding in celiac disease. You have low low ceruloplasmin levels. Obviously, on decoupling therapy, that's what you want. But liver produces ceruloplasmin, so in any form of liver failure, ceruloplasmin can be decreased. Maybe the best test we have is the urinary copper excretion. It reflects the so-called free copper in blood because that's the only proportion which can be excreted in the urine. But this is only increased when the hepatic copper storage capacity is exhausted. Or in any form of acute liver disease, and that's again a problem if you have hepatocellular necrosis, copper is released from the liver. So to make the diagnosis, you have to put all this together. We score the presence of Kaiser-Fleischer rings, the level of ceruloplasmin, the presence of neurologic symptoms, the amount of hepatic copper, the amount of urinary copper, and the genetic background for scores. And if you have a score greater 4, this is diagnostic for Wilson's disease, and this has been proven by large prospective studies to have a sensitivity and specificity close to 100%. If the score is just 3, diagnosis is possible. You have to do more tests. And with a score of 2 or less, the diagnosis is very unlikely. And that's in the EASL guidelines how to proceed. And I think it's very important. Don't start with genetics. Start with clinical symptoms, because then you make it correctly. If you have the clinical symptoms like Kaiser-Fleischer rings, neurology, then you have to score automatically and you don't need any further tests. If the score is lower, just 2 or 3, the next test is to do urinary copper, 24-hour urinary copper. If this is increased over 100 micrograms per day, then you have again the diagnosis. If it's below, the next step is doing a liver biopsy to measure hepatic copper content. Again, if it's over 250, you have done the diagnosis. If still there are doubts, you can do a mutation analysis. If you find 1 or 2 mutations and reach score 4, you have made the diagnosis. And if the mutation analysis also doesn't give you any clue, then you may have to look for another diagnosis. The treatment hasn't changed over the last 50 years. We have chelators. The newest one is tetratiamolybdate, which is currently in a phase 3 trial, the first prospective phase 3 trial in Wilson's disease ever to be done. Dipenicillamine and triantine are on the market for more than 50 years. Triantine is now licensed in Europe and can be prescribed in every country. Then we have the second option is to inhibit intestinal copper uptake by giving zinc. There's also sufficient experience with this one. I cannot tell you which one is better, but the EASL guidelines recommend to always start with a copper chelator, and if you have reached a steady state, you may change to zinc. And in patients who have a failing liver, like in the fulminant Wilson's disease or in decompensated cirrhosis, liver transplantation is a very good option. Is this evidence-based medicine? No, this is eminence-based medicine because we have no evidence whatsoever. But whatever we do, and I think this is the important measures, number 4, these are our Austrian patients, our 230 patients, followed up to 52 years. You see here the blue line is the overall survival of the healthy Austrian population over 20 years. And if you look to the red curve, you have an early mortality, but then after 20 years, still 93% of our patients are living. So it's a curable disease, and you see here about a quarter is without symptoms, a quarter is stable disease, 24% improved but still asymptomatic, and 1/4 had problems, either needs a liver transplantation or unfortunately died before getting a new liver. So the take-home message for the part of Wilson's disease has a highly variable clinical presentation. There is no clear-cut evidence for correlation genotype-phenotype. There are cofactors, I didn't mention them, which may modify the disease. One of the most important genetic factors is female sex, because females more likely develop liver disease, whereas males more likely develop neurologic disease. Environmental factors, for example, the amount of copper in the drinking water may modify the disease. And the message for hepatologists: consider Wilson disease in any patient with unclear liver disease, because it's one treatable liver disease. Now let's move to the second point, the copper deficiency related with NASH, NAFLD. This is less well known. We have made initial measurements some 15 years ago, and then systematically studied this. These are 174 patients with biopsy-proven NASH. In all of them, we measured hepatic copper content, the typical enzymes, genetic factors associated with NASH, and measured also the hepatic steatosis on a semi-quantitative scale. It's a very complex slide. It was published 1.5 years ago. What you see here is the normal range for copper. You see patients without metabolic syndromes, patients with metabolic syndromes. The black spots show you the patients who have a genetic marker for NASH. And if you just look at this, a highly significant low copper level in patients with NAFLD or NASH. This is significant in lean patients and of borderline but not significant in patients with metabolic syndrome. There was a recent paper showing that if you eat too much copper, your copper level will increase, so there's some overlap. Now, what is the mechanism behind it? And this is the first study who addressed this problem. It's a study from Austria. They studied rats in a copper-free diet, and they developed steatosis. If they refed them copper, liver became normal, and if they had a high copper levels to start with, they had no steatosis. This was published 9 years ago. This is possibly the most elegant study. You see here a study also in rats. You see they used a fluorescent marker for copper, and you see here under normal condition the liver shows up with this greenish spot. If they feed the rats with copper, you have far more copper in the liver. If you give a copper chelator, you reverse this. And if you just give a copper chelator, the signal is completely abolished. And you see here the absolute numbers and the significance of each of these. And then they fed the rats either normal diet or a high-fat diet. And you see here the baseline, exactly the same fluorescence. And after a high-fat diet, you see a doubling of copper in the liver. And you see here again, sorry, not the doubling of copper in the liver, it's the decrease of copper levels in the liver, which you can see here on this graph. Another study shows exactly the same, but gets one step further, because they said it's not just the copper deficiency, it's also the amount of fructose you give to the rats. And you see here, the AGNA stain, A means adequate copper feeding, M marginal copper feeding. You see it's not much of a difference here, although here you see already more fat in the liver. If they add fructose, even in the normal rats, fat is increased, but in those with copper deficiency, there's a huge amount of copper fat in the liver. And you see here the amount of copper. And see again here, normal copper feeding, copper plus fructose, marginal copper feeding, and marginal with fructose, and which again shows you this important combination. And this is the same finding in another study from Italy. The pictures are superimposable. Again, they have a copper-adapted diet and a copper-deficient diet, and you see here more fat in the liver here, the fat globules here, and here in absolute numbers, the lipid stain in standard copper-fed rats and copper-fed rats who get sucrose, and you see here the large difference. Sorry. So basically what they found is that copper deficiency and sucrose consumption promote a NAFLD-like pathology. So to summarize these findings of the NAFLD copper connection in experimental animals, it has been clearly shown by many studies that low copper diet leads to NAFLD. A low copper diet plus high sucrose feeding results in the highest degree of steatosis, and high-fat diet decreases the hepatic copper content. In patients, the hepatic copper content is low in patients with NAFLD, especially in patients with lean NAFLD. What I haven't mentioned is a very important interaction also with iron, since ceruloplasmin is a iron oxidase, and therefore there's a logical connection here. Thank you very much.
Thank you very much, Peter. So again, one or two questions. Then I have one, Peter. Is there a risk to overtreat, overdeplete the patients with Wilson's disease in the long term? How can we prevent that? Does it have deleterious consequences? Can you comment on that?
The answer is a clear yes. You can overtreat the patients. The most common is copper deficiency anemia. That's the first sign of copper deficiency. You may get a worsening of neurologic symptoms. The way is to monitor the patients properly. What we do is we ask them to provide urine after 3 days of medication-free, because on medication, copper is always high in the urine. And if the patient is on a chelator and you measure copper 3 days after stopping chelation, and it's in the normal range, you know that you have decoupled them well enough, and you can start to decrease the dose. It's far more difficult in zinc patients. Then you have really also looked for the erythrocyte count and the copper levels in the blood. And if you have anemia and very low copper levels, this may be also a sign of copper deficiency. What we cannot do, unfortunately, properly, and although it's in the literature, the so-called free copper, which you can calculate from ceruloplasmin and the measured copper levels, this gives you erratic values. They're not useful, and we are, not we, but everybody is trying to get a better assay. And if we have this assay, then we can really measure how much copper is there.
Thank you. One question here,
Yeah.
Arun?
Hi, Peter, great talk. Can you comment on the potential role of copper in TPN-induced liver disease? Because copper deficiency does occur in people on long-term TPN.
It has not been studied, but it's a likely possibility. And I think the problem, it could be, we could do a copper substitution therapy. It's available, it's just so cheap that nobody is funding the studies. That's the biggest problem. But for IV, it could be done.
If there are no more questions, then thank you very much, Peter, again. Thank you to the audience.